Just one comment, Andreas Sönnigsen from Salzburg. If a 90-year-old patient has to be invited to get his cholesterol checked, that is an indicator which is not an indicator of quality because there's no evidence for that.
Precisely.
Tough one.
Well,
do you want to react to that,
yes,
or do you have another thing?
I want to react. I want to pose a question to the two ladies on the podium. And Iona and José, thank you very much for setting up the stage. My question goes to Iona. You may be aware that in many European countries, doctors are paid on a fee-for-service basis. And wouldn't you say that a salary on fee-for-service also has unintended effects? And maybe, so how would you comment on that? Because you could also, I could argue, or I would argue, better pay them for quality than pay them for lots of services or rendering unnecessary services.
Absolutely. I think it's an extremely interesting question. And we once years ago had a conference in Cambridge about payment systems in general practice. And it was about how you balance the different factors. And I think a pure pay-for-performance system is equally hopeless because you just get people doing things for the sake of the money because the motivation always works at some point in the system. And we argued at the time that you should have some item of service payments, but you must have a basic practice allowance and you must have a capitation element, and that you can somehow balance all these three and get a reasonably equitable one. But it may be the time is coming where we have to ask, why is it that general practice is paid in this bizarre way, whereas our specialist colleagues earn a salary? And what is it about us that means that we have to be treated in this way with carrots and sticks? How have we got ourselves into this position, and what does it mean?
Jørgensen Andersen, Danish GP. We actually had a system where Danish doctors were on a fixed salary in Copenhagen years ago, and many theses have been written about how doctors do not work at all. So, and then also about the interesting thing that happened when it was changed to a system where they were paid for performance. Suddenly they all started to measure blood pressure and such things. So that's fee-for-service, yes. So I just can't understand why you're so, I mean, what is wrong about being paid for performance as part of your salary? You say that love and affection and all these things are very good for the patients. I think if I have a diabetic patient, simvastatin might also be good for them. And if there was some kind of remembering system that urged me to give them simvastatin, I can't see it's counterproductive. So why don't you support José's system of a multiple salary system with some capitation, some fee for service, and some pay for performance?
I do support that balance sort of thing. I don't support the pay for performance because I've seen what has happened with it in the UK with the Quality and Outcomes Framework, which I think has been very destructive of a lot of good things in British general practice. We have inordinately increased the measurement of normal blood pressure in UK general practice. Well, not the measurement, the recording of normal blood pressure. We used to measure the blood pressure before. If it was normal, we didn't necessarily bother to write it down. Now we write it down. I'm not sure that makes the world a better place. Massive. Well, because if while you're doing that, you're not doing something else. And so I think there's something, I find them something very degrading about being paid for quality. I think as a profession we should aspire to quality without having to be paid. I'm very disappointed that Danish GPs don't work unless they're, from the Danish GPs I know, I find that extremely hard to believe. But they apparently put their feet up when they're not paid any, they're not paid in a very focused way. But enough. I think you should be, someone else defend me, for goodness sake.
Janne Getessen, I'm from Norway. I won't defend you, Iona. I think you can do that yourself. I will disagree with you for one time. I think we should be paid for quality, but not for performance. Because love, compassion, loyalty, trust, these immeasurable things are such a big part of our practice, and it cannot be reduced to what we can measure. So I will try to, in Norway, to fight off QOF. We don't have it yet, but I want to defend our system, who is really an accreditation system, not of the practice, but of the practitioner. And we have to do a list of things to be recertified. And every 5th year, if we don't make that goal, we earn less. About 20%. I haven't done the numbers really good. And we can put what we want into that list of what you have to do. And the reason I think we should be paid for it is that improvement knowledge, quality practices takes time. And you need to set apart time for it. You need to have time with your colleagues to reflect on what you do, on trust, and on simvastatin, and when to stop in the old age. And I think we should do that, and I wish we should accredit GPs, and we should have indicators accessible to us when we need them. Why can't you in England use this huge database? It costs more than $1 billion, but I, as a patient in England, cannot go in and look at my diabetes data and see how it changes. In Denmark, I think they will be able to do that in a couple of years. Why can't I, in my practice, if I'd been in England, go in and pick the indicators I need for my specific project that I want to work on in my practice? So we kind of agree-disagree.
Well, I first go to Luc and then I come to Peter, and you also have a question. Yeah.
Thank you very much.
At the other microphone.
I'm Luc Seuntjens, GP from Belgium. One way to move forward is not focusing to feedback the data only to the practice or to the GP, but to organize regional feedback of data. So supporting organizations can go to work on certain topics for improvement and can go into the peer review and can tackle practices who will not perform themselves better without the support of the regional structures. So in countries where there are regional structures, circles of GPs, it's interesting to foster data to this intermediate level. And then there is not at all this destroying of the person focus of general practice, but it's on a level just above it.
Make it a bit more, you concentrate on the practice and on the help the practice might need. Yeah. Is it?
On the regional support of the practice, not on the practice itself.
Yeah, okay. Is your question related to it, Bear?
I have just another point. I'm a Swiss GP, and probably the most important part we are paid for is the time we share with patients. So actually in Switzerland we are paid by 5 minutes time we share with patient, independent of we do this by phone consultation or real meeting with patient. But what is lacking, we are not paid by the quality, additional qualities, for instance, quality circle work and other things. And I think it should be a combination of both. Should be time, and the future is female in general practice. We will have a lot of part-time colleagues working, and they should be paid accordingly, and the quality they bring should also. And I have a question about, what do you think about this?
I would never oppose being remunerated for participation in quality circles. I think the much reflection that we can get, the better. And it would be really great if our system was that you were allowed to choose the 5 indicators you wanted to work on that year, and you were allowed to set your dimensions, so you weren't, you know, there's so much worry about being accused of ageism that we are expected to prescribe statins to 90-year-olds. You know, there's some nonsense in the system that if you were allowed to take some control over it as a professional, as a practice, it sounds a bit more like what you were doing, where the practices were selecting what they wanted to work on. I mean, I think all that could be immensely constructive. It's the blanket application of someone else's definition of quality based on yesterday's evidence, not today's.
Okay.
Hi, I'm Cheryl Levitt from Canada, and I think that the issue of pay for performance is a complex quality issue. And my grandmother always used to say, everything in moderation and make sure that it's well baked. And I think that that very much applies to what we're talking about here, because I don't think that you need to throw the baby out with the bathwater. I think there are times when pay for performance can help identify a change that needs to happen, especially if it's a brand new initiative that's going to involve a lot more time. It could be part of an increase in pay, which is expected by everyone, which will help focus some of the attention on areas requiring special need. But it needs to be applied with a great deal of wisdom. Like any initiative, it has its complications and its negative elements to it, and we need to reflect on those. I mean, Iona, when you talk about data collection and not being opposed to data collection, there's a lot of data collection we are opposed to. When you talk about transparency and not being opposed to transparency, there are transparent issues that we're very uncomfortable with. So, and sometimes if we blanketly apply something that we're all in favor of it, like a religion, it means that we're not doing the circle of reflection that's actually important to say, okay, so we've implemented it, what are the complications associated with it? And next time round, how are we going to improve it and make sure that we're not making those mistakes moving forward?
Yeah.
Grandmother's cookery book is still very wise, much of wisdom. Peter, do you dare to go on?
Well, for years I'm trying to find out if I disagree with Iona, and I'm not sure yet. But the whole discussion to me is sometimes that it is very judgmental, you see. It's a judgment that love and affection for the patient is per definition good, and that treating a 90-year-old patient for his cholesterol is per definition bad. But it may be that a 90-year-old cholesterol who has a family history of all his brothers having a stroke at 94 may well have some benefit at that point. You see, you have to discuss that. And it's also true that if somebody comes for a referral, because he's very worried about his PSA, which he found out in some sort of other circuit, that he can have all the love of affection, but he probably needs a proper instruction, referral, or whatever, you see, and not so much the love. So we shouldn't be judgmental about how, what is the best treatment, transparency or not transparency, pay for performance or not pay for performance. In my opinion, it's all about clinical effectiveness. And if love is not clinically effective for that patient at that moment, it's wrong. And if it's clinically effective to treat the 90-year-old, we do it. And if we can get clearness about...
There's no evidence.
We don't disagree, you see.
No, there's no, yeah.
But there's no debate on that. No, but that's why I'm very strong favor of that each doctor should want himself this internal transparency, that he should know these things, and that is actually one indicator, does he do that or does he not do that? If he does it, he can be paid, in my opinion, a lot extra. So that was my point, but I hope I already heard we didn't disagree.